As you know, erdafitinib is again a good target. It's a drug that targets FGFR3, altered urothelial carcinoma. And when we think of all of the targets and the ones for which we need to test, of course, having a target that's easily reproducible is very important. And that's the benefit that we've seen from DNA and strategies as compared to some of the gene expression profiling and some of the more inducible targets that we have found we can't target quite as effectively. So, erdafitinib was FDA approved as a second line therapy for FGFR3, altered urothelial carcinoma. And as you've heard, we did this clinical trial in patients who had prior chemotherapy and immunotherapy. So, this was one cohort of the THOR trial. And we randomized them after chemo and immunotherapy to either erdafitinib or single agent taxane or vinflunine in Europe. And all of these patients had FGFR3 mutations. What we saw was an improvement in median overall survival of 12.1 months compared to 7.8 months with chemotherapy alone, which was also associated with a significant hazard ratio. When we look at the response rates, and erdafitinib again came in with about a 45% objective response rate. Compare that to single agent taxanes or vinflunine, where the response rate was around 11%. Now, I've mentioned several times selection matters. We've seen several trials of single agent taxanes, some with single digit response rates, some with response rates that are nearly 20%. And it often is impacted based upon the characteristics of patients enrolled. How low of a performance status will you go? How low of a hemoglobin? And I would argue this trial was a bit more permissive in allowing that performance status of 2 and slightly lower hemoglobins because we also recognize the frequency of the mutation was such that we had to screen a heck of a lot of patients to enroll in these FGF targeted trials. So, when we also looked at the impact of sequencing, because there were these early data sets suggesting FGF alterations were associated with immunologically cold tumors, and we thought perhaps it would be better to give an FGF targeted strategy prior to giving treatment with immunotherapy. And we did this trial in patients who received prior chemotherapy for their metastatic disease, no prior immune checkpoint inhibition. And patients were randomized again with an FGFR3 mutation or fusion to either erdafitinib or pembrolizumab. And what we saw was a similar median overall survival across both groups. So we did not see that significant improvement in overall survival, which was required to have a successful trial. But what we've also seen is that overlap, that crossover of the curves, where there appears to be an initial cohort of patients who benefit or do better from that cytotoxic chemotherapy, yet immunotherapy tends to win in the long term with more durability of responses. And the benefit was there for immunotherapy despite erdafitinib having twice the objective response rate. So we saw significantly more responses than with pembrolizumab, but it's the durability that again contributed to that long term benefit and the reason why pembrolizumab appeared good and we could not beat what was seen with pembrolizumab alone. And I should also say, both of those trials, when we looked at FGFR3 alterations and just simple PD-L1 expression levels, we saw that over 90% had that PD-L1 low CPS score. So, again, looking at these tests, FGF seeming to be associated with more immunologically cold tumors. But despite that, we didn't see that translation to benefit. We've also looked at combinations of erdafitinib with checkpoint inhibition, with cetrelimab, and the thought was that perhaps there could be additional benefit in stimulating an immune response in patients who had initial cytoreduction and perhaps tumor antigen release and expression. And this was a frontline trial, again, a randomized but non comparative cohort. So this was frontline cisplatin ineligible patients. And patients were randomized between erdafitinib single agent or the combination of erdafitinib with cetrelimab. And in the erdafitinib only arm, we again see an objective response rate of around 44%, which is what we've seen in the second line setting as well. When we look at combining it with cetrelimab with the immune checkpoint inhibitor, the objective response rate was nearly 55%. So, potential for benefit in the frontline metastatic setting, and also some trends toward improvement in the duration of response. And when we look at the overall survival, we saw that the median overall survival from the combination came in around 20.8 months. When we looked at the erdafitinib alone arm, it was around 16.2 months for erdafitinib alone. And with giving the combination, we also saw that median progression free survival instead of the 6 months that we've typically achieved with single agent erdafitinib, even in the second line setting, we saw a median progression free survival closer to 11 months with the combination. Now, there's one more trial that's been done with erdafitinib in metastatic patients, but this was the RAGNAR, a tumor-agnostic trial. And it allowed patients with a variety of tumors who had FGFR3 mutations or fusions. And it looked at these different cohorts based on objective response rate and progression-free survival. And what they saw was across multiple tumor types, and again, some enrichment for cholangiocarcinoma, which has known FGF mutations as well. It looked like the objective response rate across all tumors was around 30%, progression free survival around 4 months, with a median overall survival of 10.7 months. And these were all in patients who had no prior treatment with FGF targeted therapy and who had failed the current standard of care treatments for their disease. So as we think about bladder cancer, though, we've all heard that that selection matters, and that these diseases may arise along different pathways, with the majority of tumors arising along this papillary pathway, but then they develop additional carcinoma in situ, P53, other changes associated with the invasive disease that kills. And likewise, there's a group of patients up front, a smaller number, that have that early P53, early carcinoma in situ, and those have been associated with that more rapid transformation to the disease that kills, as we've heard many of the urologists talk about, that CIS requiring cystectomy. When we look at these FGF alterations, they follow a similar paradigm with enrichment in this papillary, low grade, low stage cohorts. And as we get to muscle invasive disease, the frequency of alterations drop closer to 15%. We don't believe that's due to loss of the mutation. Rather, it's due to the contribution of this carcinoma in situ P53 pathway, resulting in higher transition rates to that invasive disease with the potential to kill. So, one further area where erdafitinib is being studied, and this was an oral therapy with erdafitinib, is in that non muscle invasive bladder cancer. And it took patients who've had prior BCG, they've had recurrence, they had an FGF alteration, and it randomized patients between oral erdafitinib or investigator choice of intravesical treatment, looking at the recurrence free survival. And interestingly, we see a significant difference in that recurrence free survival, even with oral erdafitinib compared to intravesical treatment. So I think there's definite promise with the treatment of erdafitinib in the superficial setting, although the toxicity is not something that patients in that setting will prefer to have because they can remove that toxicity by having a cystectomy. And this is where drug-eluting pretzels are coming into play and currently having that potential role. So what have we learned about erdafitinib so far? From the sequencing standpoint, the benefit to patients may be best when erdafitinib is given after treatment with an immune checkpoint inhibitor. It is perhaps because there's a long-term or durability of response with immunotherapy that has not really been achieved by cytoreductive strategies alone. Although one might argue, with the degree of cytoreduction, could there be patients who might need erdafitinib before an immune checkpoint inhibitor? Perhaps they're experiencing that visceral crisis, that severe hematuria, shortness of breath, where cytoreduction matters. When we look at combinations, it may have the potential to improve the response when combined with immunotherapy and also bring in that benefit early from immunotherapy, enhancing that durability of response and benefit. But where the true role for this will be I think, in that non-muscle invasive bladder space, where we see over 60% of FGFR3 alterations present. And with these drug-eluting devices, we are able to achieve more continuous concentrations of a therapeutic in the bladder and have that potential effect on the mucosa. And I'll thank you all for your time.